Well, good morning, everyone. This is Curtis Hawks over here at Insurance Agency Marketing Services, and I want to join you, or I want to thank you for joining us for a very important webinar. We're going to talk a little bit today about how we can help you navigate underwriting a little bit more easily, and we've got a very, very important topic. We're going to be talking about diabetes and some of the challenges with that. How can we make sure we can help you to get those cases placed? Before getting into that, I did want to take a couple of minutes here to talk about some of the additional ways that IAMS is here to support your business. First up is our new producer bonus, and you can see up here we've got a number of different point totals. When you get contracted with us in your first 6 months, you automatically get enrolled into this program as you're hitting different production tiers, and all business counts, so index annuities as well as life insurance and single premium life counts for this. You can see there's a variety of different options that you can qualify for, whether that's marketing support, trips, or just straight cash, or even an iPad. And so if you've got questions about that, feel free to reach out, talk to a sales director over here. That number is 800-255-5055. In addition to that, we've got our referred producer program. If you know somebody who maybe isn't quite happy with their current IMO relationship, or you've got somebody that you think would be a really great fit for IAMS, send them our way. Not only will you get a $50 bonus when they get contracted, but then on an ongoing basis, you can earn revenue off of their production. We'll take care of everything. We'll handle all the service, and you can just sit back and collect checks. And so it's a great program. We've certainly seen that grow over the years, and candidly, those are some of the biggest checks that we cut. In addition to that, we've got our marketing reimbursement program. You can see there that you earn an additional $100 for every qualifying $100,000 of indexed annuity premium. And then on the life insurance side, $200 for every $100,000 of single premium life, as well as $200 for every $10,000 of life target. Back office support, and I think we're gonna highlight that a little bit today. Andrea Rasser, and we'll have her on here in a couple of minutes, is going to be joining me. But we're going to be talking about some of the support that you get here and some of the expertise. But in addition to that, whether it's case design, new business processing, licensing, quoting software, et cetera, there's a host of different resources that you have access to when you work with IAMS. Our IAMS website is an amazing tool. We've done a lot of work on it over the years, and so you can do a variety of things there, whether it's running quotes, getting rates, doing e-applications. We've also got our sales resource library on there, which literally has hundreds of point-of-sale pieces that are compliant that you can use with consumers. And you just need to be contracted with us to access that. And so if you've got questions on how to do that, reach out, talk to a sales director over here. That number is 800-255-5055. Taking it a little bit further, you can see here that we integrate with all of the most common e-app platforms right on our website. So you can go right to our IAMS portal and access any of these. And then take it a little bit deeper dive, I wanted to highlight here Firelight. They integrate with the majority of the annuity carriers that are out there, as well as some of the life insurance companies. And then we've also got iPipeline, which integrates with all of our life insurance carriers. Creative marketing solutions. I think creative really is the key word there. I know we're at the beginning of the year, and this is a great time to be thinking about your marketing plan for the year and what you want to accomplish. And so we've got a dedicated team of people here that is their sole focus, is helping you build your brand and grow your practice. I'd also mentioned to you as well, we've got our Ascend kickoff meeting coming up, and so that's a great opportunity, if you haven't registered for that yet, to learn even more about what we have from a marketing standpoint. Next up, we've got IAMS Wealth Management. I'm going to go ahead and launch our first poll of the day. We really have seen a growing trend in the financial services space of advisors moving to that more comprehensive approach and incorporating AUM into their business. And so IAMS has really designed this platform for that type of an advisor. And so if that's something that you've thought of and consider adding AUM to your business, I encourage you to check yes on there. We'll have somebody from IAMS Wealth Management reach out to you and talk to you a little bit about the service and support they offer. And if you're currently 65 registered and just not quite happy with your current RIA relationship, reach out and give us a call as well. So I'll go ahead and get this closed down here. Next up, we've got our Life and Annuity Academies, and let me tell you, we had an amazing series of those last year. We covered a lot of great material, a lot of great content, had some amazing speakers and presenters at those events, and so we're really excited to kick off the year, and so we've got a full slate of those this year. I'll go ahead and I'll launch our next poll here. If you've got interest in attending one of those events, it's a 2-day training event, and I mean, we pack it in. You will leave there with not only items that you can instantly implement into your practice, but you'll also leave there with some really interesting business planning opportunities that you can incorporate into your practice that can really help to generate long-term success. And so these events do fill up quickly. We're going to be making some announcements here in the near future on upcoming dates, but if you've got interest, definitely check yes, and we'll be in touch with you. I'll close that out. Lastly, we did wrap up qualification on Seaside Sanctuary, so if you've got questions on point totals, et cetera, you can go to the IAMS website, or certainly feel free to reach out and talk to an IAMS sales director over here. Well, we've got that trip right around the corner. We're very excited to be joining the agents that qualified on that for that event. And we are going to be announcing our next incentive trip as well here in the near future also. So everything that you're producing right now certainly qualifies for all of that. And then I know I said lastly on the last slide, but definitely remember to like and follow us on LinkedIn and Facebook. That's a great way to get updated information on what we're doing. So with that, let me get this closed down here real quick, and I'll get our presentation for the day up and running. With me today, as I mentioned, is Andrea Rasser. She's our chief underwriter over here, and we've been very, very pleased to have her over here with us. She's really done an amazing job, and just in the Andrea, it feels like you've been here for a long time, but it's only been, oh gosh, what, about 4 or 5 months so far?
Yes,
but she has already made an amazing impact, and she has pulled cases that were declines or we thought were no-goes into the insurable category. And so this quarter, we've got a round of, I think, some very, very important topics. We, on our previous webinar, talked about field underwriting in general, and so to kick off this year, we've got a number of individual topics, and what we're going to focus on is what are some of the more common medical impairments that consumers have that can cause issues in underwriting. And so to kick off this series, we're starting with diabetes. So with that, Andrea, I appreciate you taking some time with us today and giving some good education on this.
Thank you, Curtis. Thank you, everybody, for joining us. Hope everyone's staying warm out there today. Today, we will be going over diabetes. I chose this topic simply because it is one of the ailments that I see the most in underwriting, whether it be quick quotes or a formal case. It comes into play literally every single day. So, get started. What is diabetes? Or, as your doctor may refer to it, diabetes mellitus. Essentially means a profuse flow of a sweet substance. Not the catchiest.
Not the catchiest description,
nope,
is it?
But that's, you might remember your grandma years ago saying, he's got a case of the sugars. Well, that's exactly what this is about. So diabetes mellitus refers to a group of diseases that affect how your body uses sugar, otherwise known as glucose. We'll get into that later. This is a chronic disease. It basically occurs when the pancreas does not produce enough insulin or when the body does not effectively use the insulin that's being produced. The exact cause of most types of diabetes is unknown. They really don't know what prompts it, but in all cases, it comes down to the fact that sugar builds up in the bloodstream. Both type 1 and type 2 can be caused by genetic factors, but there's also a lot of environmental factors that are involved there. As I said, the reason I wanted to cover this is because we see it so often. So just to give you a little background there, as of 2021, over 38 million people of all ages in the United States had diabetes. It's almost 12% of the population, and over 97 million adults have been diagnosed with prediabetes. Diabetes and diabetes-related kidney diseases cause an estimated 2 million deaths annually, which is why underwriting looks at this so closely. Some people may think it's no big deal because he's just got a case of the sugars, but that is not the case. It has caused a huge increase in mortality in the United States, and over 1.4 million Americans are diagnosed every single year. All right, we're going to get in the nitty-gritty of some terminology and how diabetes really works. So insulin is a hormone that's made by the pancreas, and this helps glucose get into your cells that are used for energy. If you have diabetes, your body either isn't making enough insulin or it's not making any at all. The pancreas is supposed to release the insulin into your bloodstream, and it surrounds your cells, which allows the sugar into those cells. If for some reason the insulin is not there, that blood sugar has nowhere to go, which is why we see our blood sugar levels rise. But when the insulin is actively working, it pulls that blood sugar, the sugars into the cells, and therefore decreases the blood sugar levels. Anytime the insulin's not working, the blood doesn't know what to do with the sugar, and this is where we run into high blood sugar levels and high A1C readings. Now, glucose, or blood sugar, is an important source of energy for the cells that make up our muscles and our other tissues, and it's also the brain's main source of fuel. The blood sugar can also be derived from liver activities. It's not just from food. But the sugar enters these cells with the help of the insulin, like we said before, and it takes it out of the bloodstream. If that's not working, then that sugar just stays there and can cause a lot of problems with different nerve endings and so on and so forth. The liver helps to maintain those glucose levels to stay within average ranges, especially when your blood sugar is low. Your liver will overcompensate for that and provide more. But again, if the insulin's not working, then that doesn't do us a whole lot of good.
I have a question as you mentioned that, and I know this will probably be another topic for another webinar, but if we've got somebody whose liver isn't functioning well, can that be a factor into this as well?
Absolutely, yes.
Okay.
Okay, so there's three main types of diabetes. There are some subtypes, but the three main types that we see are going to start with type 1, which was previously known as insulin-dependent or juvenile diabetes. And this is because type 1 diabetes is typically diagnosed in childhood. It can be diagnosed in adulthood, but the majority are going to be diagnosed at a younger age. With type 1 diabetes, insulin administration is going to be absolutely necessary. They do not make enough insulin, and therefore, this is where we get the insulin administration. And without it, it can be deadly, unfortunately. Cause and prevention methods remain unknown. Type 1 diabetes is still more of a mystery than the others. And so it is looked at very, very closely and comes with a lot of comorbidities, unfortunately.
So can we take a moment and talk a little bit further about this? I mean, I know that you are screening cases, going through records every single day. And as you talked about going through that number slide, I mean, diabetes is relatively common. I mean, more than 1 in 10 people are going to have it. So with type 1 diabetes, I mean, from your perspective, it's not to put you on a spot, but I mean, do you find that maybe certain carriers are a little bit more friendly to that, or are certain carriers definitely not? I mean, is there anything guidance you can give us, or does it matter how old the person is when they get it?
It does make a big difference. We have multiple carriers who will actually decline if you were diagnosed with type 1 diabetes under a specific age. Some will go with age 10, some will go with age 15. You could now be 40. But if you were diagnosed at age 7, you will be in instant decline with a lot of carriers. We do have multiple carriers who will start taking type 1 diabetics at age 6 or 7, but there are just as many that will decline. So it is imperative to reach out and find out which carrier is going to be best for that situation. They're also going to look at the level of control, the previous lab readings, how it's being treated. All those factors come into play. There's not one easy answer, but we have at least 3 to 4 carriers that I look to first and foremost when it comes to type 1 diabetes. Prudential, Allianz, John Hancock, those are 3 of my top favorites when it comes to type 1. They are more likely to take the younger age diagnosed cases.
So I think that's good insight. I think maybe the important thing then is, because I know a lot of guys that, you know, they come across type 1 and it's just gotten declined. I guess the key point here is don't, because somebody's a type 1 diabetic, don't just make the assumption that they will get declined. Let's give us a call, let's talk it through. It might still ultimately be declined, but let's at least see what it might look like.
It ultimately could be with the unfortunate complications. However, I've seen many of them that actually go active.
Okay.
Now, type 2 diabetes affects how your body uses sugar for energy. Typically, insulin production is there, it's working, but it's not using the insulin properly, which, again, leads to high levels of blood sugar if it's not treated or it's unknown. A lot of people don't even know they have high blood sugar. Over time, type 2 diabetes can cause serious damage, especially to nerves and blood vessels. We have found that over 95% of diabetes cases are type 2, and almost all of them are driven by obesity or lifestyle issues. This was formerly known as non-insulin dependent or adult onset diabetes. However, in recent years, insulin has become utilized more often in type 2 diabetes. We are seeing that occasionally. I wouldn't say it's common, but we're seeing it more. And as it was once seen mostly in adults, it is starting to occur more frequently in children. Personally, I assume that's related to obesity in America.
Yeah.
That's an unfortunate fact. So it is no longer just considered adult onset.
Okay. So I think there's a key point there, because you talked kind of about used to be insulin dependent versus non-insulin dependent. I remember referring to it like that as well.
Yep.
And we've certainly seen more people that are type 2, that they have some type of insulin regimen in addition to maybe oral medication. So I suppose that's a good key point, is if you're talking to somebody and they mention that they are taking insulin and pills, don't just make the assumption that they're type 1 and there's nothing that we can do.
Absolutely. Yeah. Ask those questions. Make sure that they know exactly how their doctor has diagnosed this. A lot of times with insulin, we see a starting range of around table 3 to 4. But you know, if it's type 2 and it's minimal insulin, we might be able to see a table 2 to 3 instead of that 4, and maybe even better. But that's exactly why we shop those cases up front, is to find out.
Yeah. So do you find then on type 2 that you have maybe a bigger portfolio of carriers that you can look to when we've got a type 2 diabetic?
Absolutely. When it comes to type 2 diabetics, if it's well controlled and it's oral medication only with no insulin, standard is typically the best we're going to see, but we can pretty much get that anywhere. All of our carriers are usually in the game if it's type 2 and well controlled.
Okay.
As opposed to type 1, where we're far more limited.
When you say well controlled, I know A1C, and I know we've got a lot of topics here, but I mean, is there like an upper echelon of what that A1C should be?
We'd like to see that A1C at 6.5 or below. We want to see it maintained and well controlled for a minimum of 6 months. A diagnosis of typically a year is what the carriers would like to see. And they want to make sure there's not been any complications, which we'll get into some of those complications here in a few slides, but they definitely watch for complications of diabetes. Lastly, the third kind of diabetes we see quite often is gestational diabetes. Now, this involves the blood sugar levels being elevated, more elevated than the average person, but also not quite as high as the diagnostic factors for type 1 and type 2. Typically, most obviously, this is going to only affect women because this only happens during pregnancy. Typically, most women will deliver a healthy, fine baby, and things can go back to normal. However, it can come with complications. There is a risk of issues at delivery, future development of type 2 diabetes in the woman is actually increased by over 50%, and there is an increased chance of that child developing diabetes. They typically diagnose this towards the 24th to 28th week of pregnancy, using a glucose drink and checking your blood sugars every couple hours to see how it's processing that. If they find that your levels are above the normal range prior to 24 weeks of pregnancy, they will start looking at this as true diabetes and not just gestational. So if it's diagnosed during pregnancy, that doesn't necessarily mean you're out of the woods for type 2 diabetes. This also can lead to elevated blood pressure and preeclampsia in pregnancy, which is why most of our carriers are going to postpone anybody who is currently pregnant with gestational diabetes. There's far too many unknowns after delivery for them to accurately assess the risk long term.
Okay, so I know, so this is related, but a little bit off topic, but I guess maybe as we're talking about pregnancy, because we come across that, we have cases come in, I mean, do insurance companies, if an agent's got a client and she's pregnant, do they do any adjusting of their underwriting because she is pregnant, or what does that look like?
With gestational diabetes, they unfortunately will not, because again, they can't see into the future and what's going to happen after delivery or even before and during delivery. Again, it can come with a lot of complications during pregnancy, and so the majority are going to postpone until after delivery, and they're going to want to see the doctor fully release her after her 6-week checkup, and then the carriers will begin to consider it again.
Okay. What about if we've got a woman who's pregnant and doesn't have gestational diabetes? What about things like elevated blood pressure is a common thing with pregnancy, or height and weight, obviously? Do they do any factors for that, or do they just, whatever it is that you read, that it is what it is?
Unfortunately, those are areas they're going to leave what it is where it is. Now, there are a couple lab readings that they will maybe take into consideration, but when it comes to blood pressure, build, any of the main underwriting factors, they're going to look at where it is right now.
Okay. So then, let's say that we have an agent, they've got a client, she's pregnant, she's got gestational diabetes. We know that she's more likely going to be postponed during pregnancy. Is there a time frame, generally speaking? I know I'm kind of putting you on the spot here, but is there a time frame afterwards that you would wait before looking at purchasing a policy?
This is a loaded question.
Yeah, okay.
So there is. There typically will not offer it all until they've gotten past their 6-week postpartum checkup and been released from all the physician's care.
Okay.
At that point, they will begin to look at it, but the majority of carriers are not going to look at this better than standard. They will hold to that standard because, one, of the increased risk of type 2 still developing. Like I said, that number is over 50%. And two, depending on the woman's age and the chances of future pregnancies, they stay in that standard range. Okay. We do have some carriers who will, if you're 5 years out from your last pregnancy or 10 years out from your last pregnancy, over age 50 and not likely to be childbearing in the future, they will sometimes start to ignore that gestational history, and we can start getting back into those preferred rate classes. However, those carriers are kind of few and far between. There are many carriers who just stick it standard at best, no matter what. We don't care if the baby was 10 years ago. You're still at an increased risk for developing type 2, and so they won't budge. But in recent years, I have found at least a few carriers that if you're 10 years out and your levels are maintained a stable, normal status, and there is no chance of future children that they will then start to consider preferred, even preferred plus in some cases. But
Okay.
again, those are few and far between. I absolutely recommend you shop those, especially if you're at that 5-year to 10-year mark.
Okay. What about if they didn't have gestational diabetes and woman has her baby? How long before she could get up to super preferred?
With no complications,
Yeah.
that 6-week postpartum checkup is key.
Okay.
Now, every now and then we'll get a carrier who doesn't really care, but typically they do want to see that 6-week postpartum.
Okay. So that's
everything
the
has
key
been
there.
cleared. Yes.
Okay.
Absolutely. So when treating diabetes, they're all going to be treated a tad different. Type 1 diabetes, as I said previously, it requires an insulin injection for survival. Without that, you're going to be in trouble. It is absolutely key that you keep up on the insulin in order to maintain proper blood sugar levels. And type 2 typically can be managed through lifestyle changes, oral medications, and, like we said, in some cases, insulin. That's definitely not as common, but we are starting to see it a little bit more regularly than years past. Along with medications for the diabetes, it's not uncommon to see that they're also going to need medications to lower blood pressure and statins to reduce the risk of any cardiac complications. When diagnosing diabetes, this is usually just done through a blood test, pretty non-invasive. It's nothing real major. They are going to look at your A1C levels. This is measuring your average blood sugar over a 2 to 3 month period. The way this is done, the cells that they're testing have a lifespan of about 3 months, and so that's how they're able to get the average blood sugar for that 2 to 3 month period, as opposed to the fasting blood sugar, where they just have you fast overnight and then get a blood sugar first thing in the morning. That is going to look at just the past couple of days. So when somebody's fasting blood sugar comes in normal and their A1C level comes in elevated, an agent may wonder, well, how does that happen? Well, it's because those fasting blood sugars are very current. It's based on what you've recently done, whereas that A1C level is a 3-month average. So doctors and underwriters, they look at both. It's a good indicator of just how controlled that diabetes is. There is also a glucose tolerance test. This is the one that's typically used during pregnancy. They have you drink a real sugary fluid and then test your blood sugar to see how it has been processed. But the A1C and the fasting blood sugar are the two that we see the most common or the most often. That A1C, they want to see it typically below 6.5, like I mentioned. The fasting blood sugar, they're going to want to see it around or below 100. Once you get to that 100, 125 range, they're going to call that prediabetes. Anything above that, they're going to call actual diabetes. A1C, anything over 6.5 is where they start to diagnose it as type 2 diabetes.
Okay. So they're taking both of these tests for the agents out there. If you're talking to somebody, I mean, ideally we want to get both of those so we can make an informed decision. But
and insurance labs will pull both of those.
They will pull both of
Yes.
them. So if that agent's meeting with that client and they're trying to just do a little bit of field underwriting, if they can't get both, what is the one that we definitely want to know?
We absolutely want that A1C level. That is the number that all underwriters are going to look for. The fasting blood sugar is helpful, but I could go to the movies tonight and have 4 candy bars, and that's not going to be a true picture of my health if I do the test tomorrow morning. That A1C level gives them a much better read on your level of control.
Okay. Now, on the A1C, we've talked a lot about kind of where ideally you want to see it, but is there a max A1C to where if an agent's talking with a client and they say, well, it's at this, then we know, okay, there's probably we're going guaranteed issue. That's the only option.
I would like to say there's a magic number, but there's not. I've had cases come to me where an agent said, this guy's A1C is 9.9, and we found a home for it.
Yeah.
And highly rated, albeit highly rated.
Yep.
We
Yep.
did find a home for it. But I've seen them as high as 13, and obviously that's going to be a decline. But there's no magic number. I always shop them because there's a lot taken into consideration as far as, again, treatment, how long it's been treated, and how well it's been controlled in the past. Did they just recently change medications? I mean, there's so many things that can come into play. Yeah. So I wouldn't say there's a magic number there, but let's keep it towards 6.5. Now, as far as complications are concerned, and these are the things that underwriters are going to be looking for. A lot of these long-term complications develop gradually. They do not just show up overnight. The longer you have diabetes and the less controlled that blood sugar is, the higher the risk of these complications. Eventually, some of these complications may become disabling or even life-threatening, which is why we look at it so closely. Possible complications can include cardiovascular disease. There is a major risk of a lot of different heart problems. This can include coronary artery disease, heart attacks, and strokes. If you have diabetes, you're much more likely to have a heart attack or stroke. I don't have the actual numbers for that, unfortunately, but there is a severely increased rate.
Significant increase.
Yes.
Okay.
Yes. Diabetic neuropathy is basically nerve damage from diabetes. When too much sugar gets into the blood system, it can injure the walls of the blood vessels that nourish these nerves, and that really happens more so in the legs and just the extremities, the fingers, the toes. It can cause that tingling, numbness, the burning sensation or pain towards the tips of the toes or the fingertips. And it will gradually spread upwards. You may hear us ask if there's been any amputations, and this would be why, would be diabetic neuropathy. Another thing that we see quite often is diabetic nephropathy, which is the kidney functions deteriorating. It does take a toll on those cells as well, and so they will be looking at kidney functions and also liver functions for that matter. One of the other more commons is going to be diabetic retinopathy, which is damage to the blood vessels that are at the back of the eye and can eventually lead to blindness if not controlled. With all of that, we can also see foot damage, skin and mouth conditions, extra dryness, and infections within the mouth, and hearing impairment. We have found that diabetes can lead to hearing loss as well because of the way that it can damage the nerves.
So I've got a question here, and I think probably some of the agents listening are wondering. So if you've got diabetes and then you have one of these conditions in tandem, does that mean that that's somebody that's probably going to be a decline, or is, I know a lot of it depends, right?
It does. Each of these comorbidities is going to be looked at a little differently depending on the severity. We do see a lot of cardiovascular disease with diabetes that can, in fact, be insured, but that also comes down to proper follow-up with their doctors, both the cardiologist and their primary care physician. Again, maintaining stable levels in that lab work. If we find that the labs are not stable and these comorbidities are in place, that is typically when we see declines. But if we see good control, proper care and follow-up, then a lot of it we can get past where the cardio is concerned. Again, with the liver functions and kidney functions as well, we can sometimes get past those if they're not too severe. When we get into something like neuropathy and retinopathy, we start to see more of the declines. When we start seeing, that there's been an amputation, there's no control there, and those are going to be declines, unfortunately.
Okay, so probably the biggest thing then here is if you've got this tandem, that's reach out, talk to us.
Absolutely. We will shop those out. We can find the best carrier for the fit, to fit that case. And again, they're not all carriers are created equal. Some will be an instant decline, whereas others may come in at table 4. You just never know.
Is it a safe assumption that it's gonna be full underwriting? There's no accelerated underwriting, any of that kind of stuff?
Absolutely. Any time you have diabetes, especially with any complications or comorbidities, you are absolutely going to see full underwriting and APS is being required.
Yeah. So I wanted to, before we go to the next slide, we had a question pop in here and so wanted to read that out. But basically the question was, well, what about diabetes? And then what if somebody's taking weight loss medication, trying to lose weight and get back, get to a healthy weight? Does that impact the underwriting if they're trying to lose weight at the same time that maybe they're type 2 diabetic?
It's unlikely to affect underwriting during the weight loss journey. After the fact, definitely can make a big difference. But with weight loss, the carriers are going to look at the amount of weight lost in the last 12 months, and they're going to add half of that back on, because with weight loss, they have found that it's typically gained back within another year.
Oh, so they won't just take your current weight.
They will not necessarily take your current weight. If you've lost 50 pounds in the last 6 months on one of these new weight loss diabetic drugs that is out there, they're going to add half of that weight loss back to your current build. And so in that sense, it's somewhat taken into consideration. But if you're just currently in the process of losing weight, they're going to take your current build as it is, or with that additional added back. Now, with especially type 2 diabetes, prevention is key. And with that, this is what we want to look for when we're talking to a client, a proposed insured. The ideal candidates are going to be the ones that are trying to maintain that healthy body weight. As I said, over 50%. I think the actual number is like 85% of type 2 diabetes are linked to obesity. So when working with clients, you're going to want to look for those maintaining that healthy body weight, engaging in regular activity every day, trying to adopt a healthy diet, and avoiding tobacco smoking. That also will increase risk. So prevention is key. Looking for those items there are going to be your best candidates for coverage.
Okay. We had another question that popped in asking about what about gastric bypass surgery?
Oh, that's a whole different topic. With gastric bypass surgery, they're typically going to look at what type of surgery was done. They're also going to look at how long ago it's been, how much the client's billed pre-surgery and the client's billed now at the time of the application. With the weight loss, they're still going to have that 12-month rule where they add back half for the first 12 months. Typically, with any kind of weight loss surgery, the carriers, some will postpone for a year, some even 2 years. Some will look at it right away. It's another one that I would absolutely recommend calling, having us get all the details and shop that out, because they're kind of all over the board with that. And it does depend on the type of surgery that's done as well, whether it affects the absorption of nutrients or if it's a true bypass and how that all works. So there's a lot of factors involved.
Okay. And then we had one more question here before we get to the next slide, and that was on, do we have any slides or marketing material around diabetes to do some prospecting online? And so what I would mention to you as well is if you haven't taken a look at them, I think IAMS has done a really effective job of putting together a number of different marketing and sales kits that include social media messaging, email templates, direct mail pieces, et cetera. And so I'd encourage you on that one, because we could probably do a whole webinar just on the marketing pieces that we have. But I would encourage you to reach out and talk to one of the sales directors over here, and they can chat with you in greater detail about what you're looking for there.
So kind of to wrap up what underwriting is going to look at when looking at a diabetic, they are going to look at the type of diabetes. That's going to make a huge difference, whether it's type 1, type 2, or gestational. They all have very different risk factors, and so that's going to be key, knowing that information. The age of onset and when this was first diagnosed, going back to type 1, if this was diagnosed at the age of 7, that can make a very big difference with which carrier we want to go with, regardless of what age that client may be now. The client's current age and build are always going to be necessary when shopping these or underwriting them. That A1C level, again, is going to be absolutely key in determining the level of control and therefore necessary, especially when shopping these out. Most carriers will not even give us a ballpark without having that A1C level. Any complications that are associated, we need to know about those. If the client has had an amputation, has become blind, has had elevated kidney functions or liver functions, or sugar pouring over into their urine samples, all those things are going to need to be known. So I would always ask about complications. And then obviously how it's being treated. We've seen type 2 diabetics that are treated with diet control only. They don't want to take medications, and so they've changed their diet. They've lost weight. In some cases, this has been enough. If it's not, though, and those oral medications are in play or they are using insulin, those are all things that the underwriter is going to need to know. And then they will want to know, too, if it's insulin shots or if it's a pump and how well controlled that is. And they'll want to see the APS to see the history there on those levels and how it's been adjusted.
So this right here, then this slide is a pretty good snapshot of if you're talking to somebody, you're doing your field underwriting, and they mention diabetes. If we're getting all of this information, then you can pretty well get pretty darn accurate about here's the different companies that are probably a fit, and here's kind of the range that we're looking at based off of that.
Absolutely. Those are the key ingredients to shopping this one out. Yes.
Okay. Well, and I'd also mention to everybody, too, if you'd like this slide, reach out and talk to a sales director, and we can certainly get that over to you, as well as if you want the whole presentation.
And as we've stated previously, the best way to go about making sure we find the right home for your client the first time is to shop this out, to call me. We can talk through it, get all the details we need, and we can find the best carrier for your proposed insured. We've got these wonderful fact finders out on our website. We have very general health screening questionnaires that will kind of cover everything that the client may be encountering, and then we also do have very health-specific questionnaires, one specifically for diabetes as an example, that we can also send out or that can be found on our website.
And that's one thing I'd remind everybody is you do need to be contracted with us in order to access the IAMS portal. So if you've got questions about that, certainly reach out, talk to a sales director over here. That number is 800-255-5055.
You can always email me at my address there on the screen, Andrea@IAMSinc.com. You can give me a call. We can chat through it. Just remember, not all carriers are created equal. That's my new motto, my new mantra. Like I said, we will see cases that are table 4, while others are standards. We may see declines, while another carrier may be able to offer in the standard to table 2 range. So always reach out if you're not sure. Got a dedicated sales director there waiting to help as well. If I'm not available, they can take that information and get it over to me. But incorporating those questionnaires will save you a lot of time on the back end if we just do that homework on the front end and get as many details as possible right out of the gate.
Yeah. So we also regularly post, as I mentioned at the beginning, on social media. We also do emails. That's how all of you are on here today, as we send an email out about this webinar. And we've got additional education events coming up in the future. I know, Andrea, you've got a few different topics here to round out the first quarter that you're planning on doing webinars on. I think I know you want to talk about cancer. I know you want to talk about cardiac, and I think the goal here is to each month we've got another topic that we're going through and talking, and all of that goes back to our commitment for all of our advisors to make sure that you've got the best information possible in order to make the best decisions for your clients and get that business place and put those clients in a better situation. We know you all have a very tough job between the prospecting, the marketing, the policy review, all those types of things. And so if we can add some value there and add a higher service level, we're certainly committed to doing that. So I'll go ahead and while we're wrapping up here, I'll launch our final poll. If you'd like more information on this topic, if you'd like to get a copy of the presentation, if you want to get access to some of those screening questionnaires, go ahead and check yes, and we'll have a sales director reach out to you and they can help you. But to round up, Andrea, I'm really glad you're here. It's made a huge impact in a lot of different areas. I mean, topics that we haven't even talked about in our trainings yet. And for all of you there, it's not a common thing to have someone with the level of experience that Andrea has at an IMO. I mean, most of the time you're dealing with the marketer and maybe they're doing some pre-screens with the carriers. And so she brings a significant depth of knowledge on a variety of topics. And then I think the other thing about that's critically important is ultimately it's going to go to, if we're trying to negotiate, it's going to go to negotiating with that underwriter. And they really do kind of speak a different language. And so having somebody where it's not their first rodeo and they've gone round and round before, I think is critically important. So I'll go ahead and I'll get this poll closed down. And I want to thank everybody for taking some time with us today. And we will be shooting out a recording of this, and then be on the lookout for our next training event on underwriting. So thanks, Andrea, and thanks everybody for attending.
Thank you.